and that's why I thought it's a good idea to introduce him, and he will present the whole thing on my behalf. And I'm here to answer all the questions, whatever you will have at the end of the presentation. Thank you very much.
Assalamu alaikum. I'm Dr. Muhammad Nasir, vascular surgeon at Dr. Hospital and Medical Center. Today, my topic of presentation is role of vascular surgery in the management of diabetic foot. Introduction: diabetes is a global epidemic and a leading cause of death. An estimated 366 million people worldwide had diabetes. In 2011, this figure is expected to reach 552 million by 2030. Diabetes is the most common underlying cause of foot ulcer, infection, and ischemia. This is the most serious and costly complication of diabetes. It has resulted in an increased incidence of lower amputation due to diabetes. The annual mortality rate of patients with diabetic foot ulcer is 11%, and it is 22% in those with the history of lower extremity amputation. Patients who undergo a lower extremity amputation have a poor quality of life, and the 5-year adjusted mortality rate after a major amputation is 46%, which is higher than for many forms of cancer. The natural history of diabetes-related lower extremities amputation can be described as a stairway. Several reports states that up to 85% of complications such as amputation may be preventable.
Recording in progress.
You can see in this stairway, each step in this stairway to amputation is targeted for intervention to prevent the lower limb amputation. Patients with diabetes have a neuropathy which is preventable. Patients develop ulceration due to the neuropathy which is also preventable. Ulceration leads to infection and ischemia can lead to the amputation. All of these factors can be manageable. Up to 25% of diabetic patients will develop a foot ulcer during their lifetime. Foot ulcers are critical precursor to infection and amputation. Diabetic patients are 15 to 30 times more likely to undergo amputation than non-diabetics. 70 to 80% of non-traumatic low limb amputation occur in people with diabetes. A multidisciplinary team approach, as already discussed, significantly improves the healing rates and reduce recurrence and major amputations. What is the anatomy of peripheral artery disease in patients with diabetes? Diabetic patients typically have a distal arterial disease affecting the femoropopliteal and tibial segments with long segment occlusions, heavy calcifications, and poor collateral circulation. The aortoiliac segment is rarely involved. Superficial femoral artery and popliteal and tibial arteries are more commonly affected. Medial artery calcification may not cause ischemia, but can lead to falsely elevated ankle brachial index due to non-compressible vessels. The peroneal artery usually spared in the patient with diabetes. Diabetic patients frequently suffer from both peripheral arterial disease and neuropathy. PAD is present in 20 to 58% of individuals with diabetes. Restoring intrapopliteal flow often promotes wound healing, but microvascular dysfunctions also play a key role in impaired perfusion. What is the microvascular abnormalities? Arteriovenous shunting, capillaries leakage, precapillary sphincter dysfunction, venous pooling, hormonal and inflammatory changes within the vessel. Perfusion in the diabetic foot is multifactorial. Atherosclerosis is only part of the problem. How we evaluate the patient with diabetic foot and peripheral arterial disease. 25% of diabetic patients with peripheral arterial disease reports of intermittent claudication. Patient described that he has a pain on walking. Diabetic patients with ischemia also often lack typical symptoms of claudication or rest pain, probably because such symptoms are masked by underlying peripheral neuropathy. Patients sometimes mistake the symptoms of diabetic peripheral neuropathy for those of peripheral arterial disease. No single diagnostic modality accurately predicts wound healing and guides the optimal level of amputation in diabetic foot patients. Commonly used tests include ankle breaker index, segmental pressure, toe pressure, arteriography, skin perfusion pressure, laser Doppler, flowmetry, transcutaneous oxygen pressure. Each has a limitation and none are fully reliable even when used in combination. The clinical judgment and multidisciplinary assessment remains essential in diabetic patients. The imaging used for the investigation of diabetic foot, non-invasive imaging modalities for investigation of symptoms and preoperative treatment planning includes color Doppler, CT angiography, MRA. CT or MRA imaging may be limited by impaired renal functions. These are the images of CT angiography, color Doppler. What are the symptoms of lower limb atherosclerosis that leads to the peripheral arterial disease? Patient may present with intermittent claudication. In this situation, limb loss is not imminent, but the control of risk factors are essential. The critical limb-threatening ischemia, which is also called CLTI, patient present with rest pain, gangrene, or ischemic ulcer which lasts for more than 2 weeks. Limb loss is imminent, so active intervention is required. If we measure the pressure, ankle pressure should be less than 50 millimeter of mercury to document the critical limb threatening ischemia. Ankle brachial index should be less than 0.4 and toe pressure should be less than 10 millimeter of mercury. What are the factors that affect the outcome in critical limb ischemia? The smoking. If the patient is not on best medical therapy, patient has a diabetes, patient has end-stage renal disease, and the women are more worse outcome than the male, the vessel calcification. The system we use for the lower extremities threatened limb classification are Wi-Fi index, which is recently incorporated in Society for Vascular Surgeon to estimate the 1 year risk of limb loss and the improvement of the vascularity, which includes the wound, ischemia, foot infections. This is the Wi-Fi classification system which is used for the grading of the wound, ischemia and foot infection. There are 64 combinations of this system which is used to estimate the risk of amputation at one year and estimate of need of the revascularization in patient with diabetic foot. So, fate of patients with CLTI after initial treatment. This is the summary of 19 studies for 6-month outcome of patient with treatment. In this chart, you can see patient alive with amputation, without amputations are 45%, patient alive with amputations are 35%, and patient dead are 20%. What are the treatment strategies for CLTI in diabetic patients? The patient should be on best medical therapy, and the interventions which includes endovascular, plain balloon angioplasty, stenting or atherectomy, bypass surgeries, hybrid procedure, combination of open and endovascular procedures. And the last is the primary amputation. UK National Institute for Health and Care Excellence recommendation regarding the management of patients with intermittent claudications include supervised exercise program. Offer a supervised exercise program to all people with intermittent claudications. Consider providing a supervised exercise program for people with intermittent claudication which involves 2 hours of supervised exercise a week for 3-month period. Encouraging people to exercise to the point of maximal gain. The evidence that lifestyle modification and so-called the best medical therapy aimed at reducing overall cardiovascular risk significantly improve outcome in patients with peripheral arterial disease. What is the best medical therapy? Best medical therapy includes antiplatelet drugs, statins, antihypertensive drugs, should be administered to reduce cardiovascular events in all patients with critical limb-threatening ischemia, to prevent peri-procedural complications and to increase post-procedural patency rate. Aggressive blood glucose lowering is recommended in all patients with type 1 and type 2 diabetes, and threshold of HbA1c should be less than 7. Endovascular revascularization is an established first-line revascular strategy for most patients presenting with CLTI and with severe arterial occlusive disease. The bypass versus angioplasty in severe ischemia of leg. Basel 2 studies suggested that primary angioplasty might be an appropriate first-line therapy even if the patient is a good candidate for bypass. Infrapopliteal arterial occlusive disease with or without competent inflow disease is a leading cause of CLTI, most often related to old age, diabetic patients, and renal insufficiency. So the treatment of CLTI resulting from tibial vessel occlusion remains a challenge for vascular surgeons, particularly in diabetic patients who presents with majority of CLTI patients and mostly present with infrapopliteal disease. So in-line revascularization of patient remains the guideline recommended treatment to achieve relief of ischemic symptoms and promote wound healing. Isolated tibial disease. Adequate rate of limb salvage can be achieved in patients who undergoing multi-level intervention for CLTI and improve patency in patients with multi-level disease. Compared to isolated tibial disease, patients with isolated tibial disease, which is more common in diabetic patients, appears to have a higher incidence of lower limb secondary to poor pedal runoff, more extensive distal disease, and severe comorbidities precluding surgical bypass. So what is the goal of intervention? The goal of CLTI treatment are relief from the ischemic pain, ischemic ulcer, and prevention of limb loss, improvement of patient function and quality of life, and amputation-free survival. The aim of the intervention is to obtain at least one, but preferably 2 or even 3 patent crural vessels down to the distal cord. So, I am sharing with you the experience of Dr. Hospital and Medical Center. This is a case scenario. A 42 years old male with a history of long-standing diabetes, smoking, present with bilateral lower extremity pain and black discoloration of toes. You can see in the first picture the bilateral discoloration of black discoloration of big toe and left side second toe. Bilateral femoral pulses were absent. The CT angiogram revealed severe aortoiliac occlusive disease. The patient underwent with aortoiliac bypass using a Dacron graft to restore perfusion to both lobe. In second image, you can see the aortoiliac segment is diseased. This is the perioperative picture of the aorta, common iliac arteries, and this is the bypass with the Dacron wire graft. This is the second case scenario. A 81 years old male diabetic hypertensive smoker presented with CIDI. CT angiogram shows left common iliac, external iliac artery occlusions and long segment SFA stenosis with both distal runoff. So plan was to do a left common iliac and external iliac stenting and the stenting of the left SFA. This is the picture of the foot of the patient. Here is the gangrene of the second toe. This is the pictures of CT angiogram. You can see this stenotic lesions in the common iliac, external iliac, and here is the occlusion of the SFA segment of the left leg. This is the angiogram of the patient before the intervention. You can see the complete occlusion of the common iliac artery. This is a picture after the placement of stent in the left common iliac artery. This is the angiogram of the same patient with multi-level stenotic lesions in the SFA, and in this angiogram you can see the collateral circulation just proximal to the complete occlusion of the SFA. This is the angiogram of post deployment of the stent in the SFA. This is the distal runoff in the posterior tibial artery. This is another case scenario. A 60 years old male diabetic with prior second to amputation presented with right foot third to gangrene and non-healing wound. CT angiogram shows extensive multisegmental disease, tibial disease. So the plan was to do a tibial vessel angioplasty with third to reamputation. This is a picture of foot. You can see non-healing wound on the third toe of the right foot. This is the X-ray of the same patient, and this is the CT angiogram which shows the severe tibial disease, multi-segmental steno-occlusive disease in the posterior tibial artery and the anterior tibial artery and peroneal artery. This is angiogram of the foot which shows the balloon angioplasty of the dorsal spidus artery. This is the angioplasty of the anterior tibial artery, and this is the angioplasty of anterior tibial artery at the origin from the popliteal artery. This is another case scenario. A 69 years old male with a history of diabetes present with gangrene of the tip of the left great toe. CT angio reveals extensive disease involving the tibial vessel. Endovascular intervention was performed. Balloon angioplasty of the anterior tibial artery and posterior tibial artery was performed. This is the picture of patient. You can see gangrenous left big toe. This is the CT angiogram of this patient which shows the multi-segmental disease in the posterior tibial artery at the level of ankle. This is the angiogram before the procedure. And in these pictures, you can see the balloon angioplasty catheter in the posterior tibial artery at ankle level. This is the balloon angioplasty of the posterior tibial artery just above the ankle. And this is the image of anterior tibial artery balloon angioplasty. And this is the final picture after the two amputation and bone is completely healed. But here we cannot see the bone. This is another case scenario, a 65-year-old diabetic male with non-healing wound at the site of previous 4th and 5th day amputation site on left foot. For last 4 months, he had undergone a left femoral posterior tibial artery bypass with reverse great saphenous vein 5 years back. So CT angio was performed, which shows complete thrombosis of the previous placed graft. This is the scar of the previous surgery. So our plan was to do a redo left posterior tibial artery bypass with using the contralateral great saphenous vein. The contralateral great saphenous vein was harvested from the opposite limb. This is the great saphenous vein, and this is the proximal anastomosis with common femoral artery, and this is a distal anastomosis performed with posterior tibial artery, just distal to the previously placed bypass graft. What is the role of primary amputation in patient with diabetic foot? What are the indications? Patient in whom there is a necrosis of significant part of the foot bearing area. Patients not suitable for any kind of revascularization, unable to use for weight bearing like charcot, open joint, very limited life expectancy to terminal illness or comorbidity conditions. So it's better to go for primary amputation. So the treatment regime after the intervention is there is no consensus double antiplatelet therapy with both aspirin 75 mg and clopidogrel 75 mg are recommended for 3 to 6 months after intervention, and patient should be on single antiplatelet thereafter for lifelong. Some recommend a more aggressive triple regime including low molecular weight heparin for 14 days has been proposed after treating complex lesion. What is outcome after the intervention? Technical success rate of intrapopliteal PTA are reported to be as high as 80 to 90%. Success rate will depend on the definition of success, the severity, stenosis versus occlusion, and the length of treated lesions, and quality of inflow and outflow, and the presence of calcification, diabetes, and renal insufficiency. Up to 80% 2 years limb salvage rate after balloon angioplasties are reported. So what is the take-home message? Effective diabetic foot management is incomplete without proper vascular evaluation. Early identification and timely revascularization by vascular surgeon are critical to save the limb. A multidisciplinary approach with vascular surgery at its core significantly improve outcome in patients with diabetic foot ulcer and critical limb threatening ischemia. Please revascularize before you amputate. Thank you.